So I had the privilege of chairing a session that was really trying to drill down into what we're doing both in consolidation and maintenance, and specifically with the use of novel approaches with immune therapies. We've done tremendous amount of work to better understand the use of quadruplets up front in now nearly all patients. But there's still equipoise, there's still a question about what is the ideal consolidation, how long should it happen, and similarly, what is the ideal maintenance and for how long should it happen? Is it single agent maintenance? Is it double agent maintenance? And now with the infusion of all of our new immunotherapies, be it CAR T-cell therapy or bispecifics, how do they get incorporated into that? So it was really quite a fascinating and dynamic session for us to think through these things a little bit, with really the majority of patients now getting to at least a VGPR with their induction, with or without transplant. What do we do thereafter? And so the session I think was very informative because it not only shared with us the data of what we know already in terms of some of the benefits of consolidation, the benefits of maintenance therapy in particular already with the backbone of lenalidomide, but also looking to the future about ways in which we may be able to incorporate changing mechanisms of action to a CAR T or a bispecifics, and what endpoints we should be looking at to ultimately give not only a deep but a durable response for our patients with ideally the best quality of life. As I always say, ultimately being able to stop therapy, because every patient loves to be on nothing.